Welcome to the Hepatitis C Action and British Viral Hepatitis Group Operational Delivery Network Stakeholders webinar. I first of all should compliment the organizers for timing it so well, just the day after Hepatitis C discovery received a Nobel Prize. This medical achievement has been labeled as a Cinderella of awards because it's been thought to have been ignored or underrated. I'm Guru Aithal. I'm Professor of Hepatology, University of Nottingham. I'm a President of BASL. It's a privilege for me to chair this meeting. My involvement with such an important work is small, and I got some insight when I was recently working with Sumita Varma on a grant which was delivering service to homeless people. I still remember when we were trying to extend the age group of this, the GP who was in charge of this service highlighted that the median age of death in this group was 43. So this, I would say, brought home to me that how challenging it is for the work that you are doing. I would say in terms of hepatitis C, the biggest gap as I see it is between efficacy and effectiveness. And your work is the one that fills the gap. And it's similar to the hepatitis C discovery. It's taken about 50 years for us to get to a point where one can think of hepatitis C elimination. So I will start inviting the speakers. Just before that, some housekeeping messages. First of all, the question and answer sessions will be at the end of the few talks. They are scheduled, you can see. So if you have any questions during the talk, please type it in the chat and chairs will attend to it. And the speakers and others, please mute your phones when you're not speaking. And the schedule has a change, which you will get to know. With that, I will invite first two speakers, Professor Graham Foster, National Clinical Lead for ODN, NHS England, and Mark Gillyon-Powell, Head of the Program, HCV Elimination, NHS England, again, to talk about the national perspective. Over to you.
Thank you very much for the introduction, and thank you as well for asking us to come along today and give a national perspective. I'll be fairly brief, and then I'll hand you over to Graham. I suppose a couple of key things that I wanted to mention were people might be aware, some might not, but obviously Q1 and Q2 have been very difficult this year, 2021, for everybody. But just looking at the national figures for those entering treatment for Hep C, we've probably done a little bit better than we expected. We did think that maybe in Q1 we would have nobody entering treatment, in Q2 similarly, or very few. But actually in Q1 and 2, I think because of some of the sterling work that was done around the homeless populations and the temporarily housed, we actually made a reasonable amount of progress. Not to the extent that we were treating people last year, but actually better than we expected, I think. So as far as we can tell, looking at the trajectories and bearing in mind where we are with COVID at the moment, we're still hoping to treat around 10,000 people this year, this financial year, so 2021. It was 12,500 last year, so actually doing 10,000 under the circumstances we've been under will be a real achievement. And I just really want to say thank you to to the ODNs and all of our other partners for really sticking with it and working through some of the most difficult times any of them will have ever seen. Okay, the other thing that I wanted to just mention briefly is, and some of you will again be aware of this, in terms of the national Hep C team, Hep C elimination team, up until I pitched up, it was Helen and Graham. It was the Helen and Graham show, really, at a national level, which for the size of the programme and the amount we needed to achieve was obviously quite stretched, I think it's fair to say. So I was just going to mention to you, obviously, I'm now in post as the head of programme for Hep C Elimination. Graham is still with us as our national clinical lead for hepatitis C, and Helen is still working as the national programme manager on data strategies to eliminate and introducing new national elimination initiatives and developing those as we kind of move along with the cohorts that we're trying to find. We've also appointed a new improvement and delivery manager who will have been in touch with some of the ODNs, maybe not all of them at the moment, who has a background in both criminal justice and public health, which is really useful, and a project officer to actually make sure that we all know where we're supposed to be, when we're supposed to be there. So it's we've developed a little bit as a team, and I think you'll start seeing some of that coming out in the products that come to you from the team and the support that we're able to offer. Just in terms of the programme and where we're up to, there are obviously some elements of it that are kind of business as usual that we've been running for a year or so now, that we're trying to either increase the value of those parts of the programme or continuing to deliver them. There are some areas that we really need to make some further progress on that we're concentrating on at the moment. So things like getting back into prisons, if at all possible, to do the intensive test and treat visits is really important. Prisons are in a very difficult situation at the moment, and we're starting to see some further impact of COVID wave 2 in some of the prisons. So we're having to tread very carefully, but we do have 16 or 17 prisons that have identified that they want to carry out work between now and the end of the financial year, between now and 31st of March. So we're going to work with them and with any others who come forward to make sure that we can do the work as effectively and as safely as possible. The primary care work is moving ahead. We have a significant number of ODNs. I think the last count was 13 or 14 of the ODNs doing some work with the patient search identification tool that is part of the MSD elimination initiative. So we're starting to see that rolling out, and we're learning more about the tool as that's happening. Probation, we've just started to extend into, and a number of intensive test and treats have taken place in approved premises. The next step after that will be to start looking at our post-sentence supervision cohort, some of whom we will have caught in prison and been able to test and treat, some of whom we won't. And then we'll move on to our community sentence rehabilitation requirement cohort within probation. So there's a significant length of work stream within probation. And again, drug and alcohol services, we really need to see an increase and improvement in terms of testing in drug and alcohol services. We've lost a significant amount of ground in relation to that. The developing bits, I suppose, and Noah, I don't know if you want to just flick up the slide very briefly for me. Yeah, so this is overall what the programme looks like at the moment. I have to say this changes on an almost daily basis. But there are some areas in here that we haven't actually been looking at yet. And we've just started because we've got that increased capacity. So over on the right-hand side of the document, you'll see scoping low return areas. So between improvement and development, improvement and delivery manager and PHE, we've started a work stream looking at testing in antenatal services. and a significant sexual health pathway that takes into account MSM, HIV co-infection, and commercial sex workers as a part of the scoping, to see how we can be doing better in those areas. Are there cohorts that we're missing? Some ODNs will already be into those, and a significant number won't be. So we're starting to do some of that developmental work, and we're learning from what we've already done as well. So things like in the second column under hidden populations, find and treat. People will be aware of OWL's ban in London. We now have the opportunity, because of a number of business cases that are coming in from ODNs, to start looking at those community vans across the country. So going out and providing a proper Hep C and wider health intervention to communities that are really difficult to reach, either because of geography in places like the South West Peninsula, or because of demographics, so homeless populations, clusters of homeless populations, for example. So looking at different ways that we can try and find that cohort of patients that we need to find. And I suppose the key message that I would give really is that we need to be in a position where we're testing more people than we've ever tested before. That's really difficult in the circumstances and with COVID. But if we don't do the testing, we don't do the treatment. If we don't do the treatment, we don't eliminate. So I think the kind of starting point and the rallying cry would be to say, test, test, test. And I'll hand you over to Graham.
Mark, thank you very much indeed. Thanks for setting the stage. If we move on to the next slide, please, for me. Fantastic, thank you. So the first message really is to reiterate what Mark said, and I would go a little bit further than we haven't done badly. I think we've done extraordinarily well, and that's really a tribute to the teams, many of whom are represented today, who have maintained a level of treatment in England that is significantly higher than just about anywhere else in Europe. So if you look at most of our European partners, hepatitis C treatment has decreased to almost zero. So virtually no treatments in the majority of Europe, whereas we've maintained a treatment level about 30% of where we were last year. That has not been easy. That has required some huge amounts of effort from everyone in the teams. The Hepatitis C Trust peers have, I think, played a pivotal role. And I know that nurses who've been left to carry the can whilst colleagues were deployed on COVID duties have gone the extra mile and then some. So I think the first message from us is a big thank you for keeping us going and getting some patients treated. Next slide, please. But if we're going to move forward in the COVID era, we have some very big challenges. Whatever happens over the next 6 months, there are going to be restrictions on movement. There is going to be a variable level of lockdown. I suspect not quite to the level we saw a few months ago, but there's no doubt there will be significant restrictions. All of our hospitals are going to have a significant burden of COVID patients to treat, and we're all going to have to roll our sleeves up and help out. So that means we have to get a bit smarter, and that means we have to get a little bit cleverer and perhaps shift some of the things we do. Mark made the point about testing, and testing is absolutely pivotal. What happened in COVID is that addiction service testing disappeared off a cliff. It fell by 90% in most addiction services. So most addiction services just stopped testing. What did happen, which I think long-term will be hugely beneficial to us, is that people did innovative, remarkable programs going into temporarily housed hostels where people who were street homeless had been housed as part of the COVID pandemic, and they provided high quality healthcare. And I want to stress that what good teams did, and you were all good teams, was to provide healthcare, not just hepatitis C. People went in with teams of primary care physicians, mental health nurses, homeless practitioners, homeless charity workers, and offered healthcare alongside hepatitis C treatments. And the outcome of that has been a very significant increase in homeless populations accessing healthcare and getting rid of hepatitis C. And that's just a win all round. So that's what maintained the testing and treatment rates in the first COVID challenge, but clearly that is a finite population, and I suspect that the find and treat programs are going to start to, inverted commas, underperform because we've treated and tested most of those people who wanted to. So that's going to be a challenge to replace, and we need to think about how we do that. Despite all the challenges, we have kept treating people. And to do that, we are going to have to move the way we treat, the way we access drugs. And in the COVID era, people came up with some really clever ways of moving drugs around. The peers acted as workhorses carrying drugs. People were dropping drugs off at pharmacies, sending them in the post. And all of those systems need to be continued, I think, as we go forward. And we'll show you how we plan to make that easier for you to manage. Next slide, please. So we've got to test easier. Testing has got to be a simple process. This is a proposal that has now been ratified by all of the big clinical societies, BASL, BSG, BVHG, etc. It'll be on the NHS Futures website. My slides are available. And this is our current recommendation for a pathway. There are two absolutely key features to it. The first is that everyone at the first test gets a genotype if at all possible. And the second is everyone gets tested for cirrhosis. Both of those are designed to improve quality of care. What we have at the moment is a system where people get tested in drug services. If they're antibody positive, they come back, they see a hepatitis nurse, they get an RNA test, then they get a genotype, and then they come back for treatment. That's a lot of visits, that's a lot of movement, that's a lot of exposures, and we don't need those. The first test can be used to test for everything. A dried blood spot test can be used to give us a genotype. So there's no reason at all why someone in a drug service who has a single dried blood spot test, perhaps even a postal test, that test can be tested for antibody. If that's positive, they can then have an RNA and a genotype. So in a single visit, they get all of the hepatitis C workup. A number of groups have started to introduce that. At the moment, it's embryonic and the numbers going to the labs are small, so there's quite a delay, and that's something we need to address. So we're working with the dried blood spot test providers to try and make this routine. There will be some issues here. There will be issues about funding because drug services quite rightly say we're paid to test. Genotyping is a treatment test, so we're going to have to find a way of moving the money around in the right place. But that's the goal. The goal is get everything done at the first visit. There is, of course, the option of pangenotypics, and I don't like that as a default position. I don't like pangenotypics as the default position because, in my view, it starts to breed discriminatory care. I'm not interested in care that says you're a drug user, you get this pathway, which is less good than somebody else who isn't a drug user. That's not where we're going. We know that some genotypes are better treated with some drugs. If you've got genotype 1, you can have a 1-tablet 8-week regime with soft lead, or a 12-week soft vel regimen, or an 8-week 3-tablet regime. Most of us, if we were given the choice with genotype 1, would like a single tablet, just an 8-week course. We need to offer that to everybody. We know that there are some strains that are just a bit less sensitive to the pangenotypics. These esoteric genotype 1 substrains, the 1Ls, the 1Ks that Kosh Agarwal described a little while ago, they don't respond terribly well to our standard pangenotypics. You need to know about them. We know that in people with cirrhosis, some of the drugs are potentially slightly less effective. We know there are concerns with people bordering decompensated cirrhosis. Everyone needs a proper workup. And that, in my view, involves a genotype. And as we go forward, of course, we're going to be thinking about screening for liver cancer. There's a lot of evidence that genotype 3 is more cancer prone. So I think the algorithms for cancer screening will move in the direction of genotype 3s are screened at lower levels of fibrosis than perhaps the genotype 1 patients. We want to have a standard of care that is the same for everyone and that maximizes access to high quality care. And that means genotyping. There are circumstances, of course, and we've all seen the advantages in remote settings of using a Cepheid one-stop test. And there are people who come to my clinic who desperately want to start treatment immediately. They don't want to wait for the genotype, and that's fine. They're perfectly entitled to ask for and get rapid pan-genotypic care. But we mustn't build pathways that discriminate. We have to build pathways that provide best possible care, and that means genotyping. So we will look in and work with you to build genotyping into the algorithms. There's no reason for it to delay. If we get the lab set up properly, if we get the funding sorted, we can genotype on the first test, and that's what we need to do. There may be circumstances where point of care testing, point of care RNA testing and immediate treatment is the only way to offer care, and that's fine, but that should be for a minority of people. The other point, next slide please, is we need to make sure we've got everybody assessed for cirrhosis. So we want to include genotyping and cirrhosis. And if you look at the next slide, please, this is the data that we've based the cirrhosis assessment on. So this is the National Registry. This is nearly 50,000 patients. And I've just looked at the data for the percent with cirrhosis by age. And at the top chart, you can see that if you're under 30, your chance of having cirrhosis is virtually nil. And that applies to all patients and to people with a history of injection drug use. If you're under 30, your chance of cirrhosis is almost minimal. But that is only 4% of the patients. So if you don't screen everyone for cirrhosis, there's only 4% of your patients who are not going to need screening. By the time you've reached the age of 40, your chance of having cirrhosis is 1 in 10. So that's a 10% plus chance of having cirrhosis. And that applies to about 30% of our patients. So my view is that if you don't screen very young patients for cirrhosis, you will not screen a tiny proportion of people, because the majority of people that you're seeing are going to be in an at-risk group for cirrhosis. So we need to build pathways that have a cirrhosis assessment built in, whether it's a FibroScan, whether it's an APRI, but we need to make sure that somewhere in the pathway there's a cirrhosis assessment. Now, of course, there may be settings where you want to start someone on treatment, get them engaged in services, and then look to do a FibroScan later on, and that's fine. But we don't want to deliver substandard care. We don't want to disenfranchise people who are most at risk and people who are most disadvantaged. They're the guys that need the assessments. We're not interested in just clearing hepatitis C. We want to make people better, not just clear the virus. And I think there is a danger if we just rush to clear hepatitis C, throw the pills around, we'll forget the human being wrapped around the virus. And that's important. Next one, please. So we're going to get much better at testing. We're going to make it easier. You've seen that the pharmacy testing program has just started. That is, I'm afraid, going to be a slow burn because they're influenced heavily by the flu campaign at the moment, and rightly so. But that will start to kick in hopefully next year, and you should start to see referrals coming into your ODN. Some of the drug services are using postal testing, dried blood spot testing by post. We love that idea. We're probably going to set up in the new year a website where people who think they might be at risk of Hep C can register, order a postal test, and we will then send the positives on to you as the local ODN lead to get them onto treatment. So that, I hope, will be coming in the new year. A lot of you have been using the peers. The hepatitis C trusts have been a real step forward, huge impact on our testing and treatment rates, and many of them are now trained in testing and have been doing it very successfully. So if you haven't got your peers testing, get them trained up. And you've heard a little bit from Mark about our plans to roll out vans, equip vans and move them around. Again, the aim is not just to find people with hepatitis C and get rid of the Hep C. The aim is to find people with health problems, get their health problems sorted out, and as we're doing so, improve their hepatitis C status. But these vans are not just a sweep through, clear hepatitis C, move on. It's important that we treat people, not just viruses. Next, please. We need to deliver the drugs, of course, and that's not going to be easy in the COVID era. We don't want people coming to hospital, people coming up to collect a month's worth of drugs 3 times before they are discharged and go back to their SVR12. That's not a good model in the COVID era. A lot of you have been using peers to deliver drugs. Some of you have been dropping drugs off in addiction services, and some of you have been dropping drugs off in pharmacies. All of those were areas that we had concerns about pre-COVID. We're now well past that. We now think peers are a good way of delivering drugs. We've shown that it works. We know that if we're sending drugs to addiction services, some of them will not get dispensed. People won't turn up. People will forget about them. They will run out. If that's the case, we will pay for lost medication. We're not going to penalise networks who lose drugs in drug services because people haven't turned up. We want you to try these things. We want you to take a few risks, and we will cover the costs. The secondary dispensing rules is when you leave drugs for a named patient at a pharmacy. That is technically thought to be close to being illegal. You'll notice the slight vagaries there because it's always been a grey zone. We've now officially decided it's a very light grey, and if you want to leave named dispensed drugs at a pharmacy for collection, that's okay by us. Next slide, please. So we need to get going again. We're starting to see addiction services opening up. Please get engaged with them. Please start to put a bit of pressure on. Mark talked about the prison and probation services which are moving. Many of you are involved in the GP testing schemes, and the new testing programs in low yield areas are just about to get going. So there's quite a lot moving forward and quite a lot moving at pace. Next slide, please. So the final slide is really to emphasize how well we've done, and that is a tribute to everyone in this room. This has not been trivial, this has not been easy, but England really has led the way in keeping a hepatitis C service going in very difficult circumstances. We want to take all the positive things that have come out of that, and we will continue to support you. If you want to take some risks and try new testing methods, try new drug delivery methods, we're very happy to get behind you. If a few drugs get missing, if it costs a little bit more, we will accept that. We know you need help and support, and we will stand with you, and we'll cover the cost if things don't work out. So the final message, both from me and Mark, is please just tell us what you need. We'll try and help. You know all the bureaucracy and all the challenges of working within the NHS England framework, but we have managed to do extraordinary things over the last few months. I know you'll continue to do that. And we're here just to help, just to assist, and we'll do whatever we can. So thanks for all you're doing. And I think I'm going to hand over now to Fiona, I believe his name.